Thank you, Sally. So we are talking about predicting treatment resistance in people with schizophrenia. And the main theme of the BRC is precision medicine. And in traditional medicine, we usually apply, including psychiatry, we usually apply the same treatment, which is on average the best treatment to all patients, but not all patients benefit from the treatment, and some might even have adverse effect. In recent years, there was a new emerging approach, precision medicine, which is defined as an approach for treatment and prevention that takes into account each person's variability in genes, environment, and lifestyle. And based on these characteristics, the aim is to identify the best treatment for a person. Precision medicine is only made possible in recent years by the provision of new big data, such as genetics, wearable data from the radar platform, as we heard this morning, and in our case, electronic health records. And as well, it's also made possible only by the high-performance computing technology that now allows us to effectively collect, process, store, and analyze big data. So the aim of precision medicine is to predict treatment response and to assign then a patient to the best available treatment. Our study aims to provide to the theme of precision medicine by developing a model which predicts treatment resistance in people with schizophrenia. This is of great importance because about 30% of people with schizophrenia do not respond to standard antipsychotics. They are said to suffer from treatment-resistant schizophrenia, or in short, TRS. It is assumed that TRS might be biologically distinct from so-called regular schizophrenia, and there's an urgent need to develop new treatments for people with treatment resistance. So the aim of our study is to identify patients with a higher probability of developing TRS using routine clinical information available at the first presentation in the clinic. This would allow, if such a successful model would allow the clinicians to be informed about the risk of a patient about developing treatment resistance. But it also would allow to identify people at high risk of developing treatment resistance. And these people could be recruited for clinical trials where we could assess new treatments. So that's my part, and I want now to hand over to Deborah, who will talk in more details about the study.
Thank you very much, Daniel. Good morning, everyone. So to determine predictors of treatment-resistant schizophrenia, we used the BRC Clinical Record Interactive Search System, the CRIS data, and the SLAM NHS Foundation Trust Clinical Records. We extracted data for a cohort of 1,400 people with the first prescribed antipsychotic after 2007 for a time-to-event analysis in a window of 11 years, starting from the date of first prescribed antipsychotic to the event treatment resistance or death or end of window. In the cohort, 181 people developed TRS, so 13% was the prevalence at the end of the study. And we extracted data for 31 predictive variables with, on average, 10% missing data. Because of the low number of events per variable, we could not apply the classical Cox proportional hazard regression model, which is the most common method to analyze time-to-event data. But we penalized it through the lasso penalty. Let's say it's a statistical learning version of the Cox regression model. And we use the lasso penalty because it allows to have many variables relative to sample size, or in our case, number of events. It reduces variance of predictions with shrinkage of coefficients towards zero. Some of them actually become zero. And this introduces some bias in the estimation, but this allows automatic variable selection and so delivers interpretable models. The missing data were imputed using k-nearest neighbors imputation. We assessed model performance for the model through discrimination and calibration. Discrimination is the faculty of the model to separate between people with the outcome and without. And calibration is the measure of agreement between predicted and observed outcomes. As a measure of discrimination, we used the Arles concordance statistics, or C index, ranging from 0 to 1, with a common cutoff of 0.7 or more, indicating a good discriminative performance. And if the C index was 0.5, this means that the model failed and didn't predict better than chance. To measure calibration, we use the calibration slope, where a calibration slope of 1 will mean perfect agreement between observed and predicted outcomes. We also assessed model validity for the whole process of our model development, including imputation of missing data. In order to address this, I will introduce the concept of apparent validity, which is the performance of the model on the development sample. But usually apparent validity is optimistic, and therefore we assessed internal validity for our study. And the internal validity looks at how the model performance is reproducible in the underlying population from which our development sample was drawn by testing the model on unseen data. And the method that we used for that was Arles optimism correction through repeated cross-validation. However, the gold standard for validity is external validity, which evaluates generalizability of the model to other plausibly related populations, but we didn't have external data to do so. So now I'm going to talk about the results. Here you can see some descriptive statistics of our development sample. And as we've seen, there were 13% people who developed TRS at the end of the study. TRS were younger on average, seemed to be younger on average. And overall, there were more male, more people with a black ethnicity. This is because of the area from which the data was extracted. And most people overall had schizophrenia, while among the TRS people, the most common diagnosis was undetermined. This is because at the date of the first prescribed antipsychotic, there was no data available about diagnosis. The Cox-Lasso regression model performed fairly in discrimination with a 60% C index, internally validated C index, and a calibration slope just above 1, which indicates some underfitting of the model. In our study, at each year, we compared the positive predictive value, the PPV, and the TRS prevalence. So the positive predictive value is the proportion of positives which are correctly classified, and by positive I mean a person that was predicted to be TRS, to have TRS, treatment-resistant schizophrenia. So if we take some people in the population which are predicted at 2 years to be TRS, treatment-resistant, this will mean that if the positive predictive value is 4%, we know that 4% of these people will develop treatment-resistant schizophrenia. And this is almost double the prevalence at 2 years. I know that this positive predictive value is not enough for a clinical tool, prediction tool, in order to be applied in the clinical practice. But clinical trials wanting to recruit 2% TRS people, so we wanted to recruit people that will develop TRS in a proportion of 2%, might need to recruit almost half of the patient. For the Cox-Lasso regression, selected 7 predictors, including diagnosis, mood disorder, age, cognitive problems, patient days, community face-to-face days. And for each selected predictor, we plotted the Kaplan-Meier curve for the survival probabilities for TRS. by levels of the predictor. So if the predictor was continuous, we just dichotomized it according to median or mean, just for the plot to be visualized and have a understanding of what's going on. So here, for example, here you can see that diagnosis was selected, and people with other prolonged psychosis were less likely to develop TRS overall. How do you read this plot? But let's see, on the x-axis there is time in days. At approximately 3 years, we can see that people with other prolonged psychosis had a 97.5% probability of not developing treatment-resistant schizophrenia, compared to 92.5% probability of not developing treatment resistance among the people with other diagnoses. And you can see that at the end of the study, for the people with other prolonged psychosis, 85% did not develop TRS, compared to almost about 80% for the other diagnoses. We saw that people with a minor cognitive problem requiring no treatment had a higher risk for treatment-resistant schizophrenia. Then there was the people not having a mood disorder were more likely to develop treatment-resistant. Then the younger people had a higher risk for treatment-resistant. And having more inpatient days 3 months before the first antipsychotic day and 3 months afterwards, again, was a risk factor for TRS. Finally, also having more community face-to-face days was people having more community face-to-face days were more likely to develop treatment resistant. So after recalibrating all the coefficients for our model, we presented the Cox-Russell regression model developed in this project through the equation, of course, and also through a nomogram. The nomogram are a graphical representation for prediction models, and they have a long history in the pre-computer era, but they are still very useful today for people, for clinicians, and for patients, because they can understand the reasons of their predicted outcome through this graphical representation. So you can see here there is a reference line for reading scoring points that ranges from 0 to 100, and each predictor will add up some points to a total. So for example, if a person is 30 years old, we will have about 78 points added up to a total, which will be linearly corresponding to the linear predictor. So we will look at this total point line, and this will be transformed into predictive probabilities at 1 to 5, 10 years, or what we are interested in. So here you can also see that nomograms are very interpretable. As you can, it is very clear how the different predictors are relatively important. For example, age will add up to 100 points, while all the others, for example, inpatient days will only add up to about 10 points for the most. So now we have an example of how to read the nomogram. So if a person is age 30 and got a schizophrenia diagnosis, 34 inpatient days 3 months before index, and 50 inpatient days 3 months afterwards, and 15 community face-to-face days 3 months before, and having a minor cognitive problem and a mood disorder, this is how we will read it. So if we have a mood disorder, we will have a 0 point for mood disorder. We will have 6 points for inpatient days, 10 points for cognitive problems, 18 for community face-to-face, 28 for inpatient days, pre-index, and 23 for schizophrenia diagnosis, and 78 for 30 years old. we total them up and we have 173 points. And then we read that we have at 2 years, for example, a 14% probability of developing TRS. So to summarize the results, we had a fair internally validated C index of 60% for our Cox-Lasso regression model, and this was a first step in order to develop a prediction to help clinicians to identify people at risk of treatment resistance at an early stage. And even though the positive predictive value is not enough good in order to be implemented in clinical practice, at least it can already be used for screening, for recruitment, for clinical trials. And this was the main reason for the funded project by Lundbeck. This is the whole team that contributed to this study. Thank you very much for your attention.
Very good.
Thanks. I think we've got time for just one question. Anybody? Can't see any hands, but that might be because you're all in the dark. Oh yeah, here. I think we've got one here. Thanks.
Hi there, I'm Samir Johar. I work as a consultant and a researcher funded by the BRC. But I guess James might comment on this, but how did you define treatment resistance using CRIS? And also, I think one of the most interesting parts of your data was actually showing the prevalence of treatment resistance increasing after 2, 5, and 10 years. Because I don't think it's basically being recognized early enough, because rates of secondary treatment resistance aren't really that high. So apologies if I'm putting you on the spot here, James.
No, very, very happy to answer that, Samir. So apologies, I didn't contribute to the presentation because I wasn't sure if I was going to be able to be here today. But so what Deborah didn't mention was actually the huge amount of work that went into this study in terms of manually validating case notes, because what we originally intended to do was to have an automated way of determining treatment resistance from the CRIS records using natural language processing, etc. But it quickly became clear that there were the definition of treatment resistance, which was a failure to respond to 2 different antipsychotics, each of an adequate duration and dose, was not going to be something that we could implement, certainly not in the time with the resources that we had available. So we used a combination of natural language processing to identify particular cases and identify points in time where they changed medication, and then we some of our colleagues who were working with us actually physically read the notes to see whether a change in medication, for example, was due to a side effect or was it due to non-response, etc. So it was, we tried to estimate the number of person hours of work that went into the study, and it was, how many, do you remember how many it was? It was
44% were manually coded.
Yeah,
and,
how many person hours work went into
I can't remember anymore, but it was a huge number.
It was thousands anyway, yeah. Thank you.
Thank you very much. Thanks.